Well, here we are back with part 3 of chapter 46 and patients with special challenges. When we left off on part 2, we were kind of talking about some of the issues, problems, diseases, disabilities, whatever you want to call it, that this group of people often struggle with. It's also important to kind of make a little bit of a distinction here that while we are talking about patients with special challenges, doesn't necessarily mean that these challenges are really high degree challenges. These things can actually be affect people and be a part of their lives that otherwise lead a pretty normal life, a pretty normal existence aside from the challenges that they have. Or it could be, on the other side of the spectrum where there are significantly debilitating challenges that they deal with, either, affecting their mental capacity or, maybe even just affecting their physical capacity. And that's why it's important to not kind of pigeonhole our patients. Just because someone has a physical disability that is very debilitating doesn't mean that intellectually they suffer in any kind of a way. So it's important to not, make that assumption about anybody, about what someone's intellectual abilities are, until that becomes known. And then the reverse is very true. Someone could have, seem, on the surface, very average, however, have some significant disabilities that may involve, hearing or speaking or intellect or, those kinds of things. So these can affect anybody. So we're really talking about anybody that has any one of these challenges and not just patients or people with special needs. We're just talking about patients with special challenges, and this is those. Visual impairment is where we'll start off here with part 3. And of course, these visual impairments can actually result from both congenital and acquired conditions. So, it can be a variety of factors that cause this. Genetic factors may actually increase the risk of vision loss later in life. And some congenital causes of visual impairment include fetal exposure to cytomegalovirus. Of course, there could be hypoxia during delivery that can lead to permanent vision problems. Albinism may result in reduced visual acuity from birth. Hydrocephalus can affect the optic nerve pathways and cause visual impairment. Excuse me. Increased or long-term high flow use of 100% oxygen in the neonate can cause problems. This has been long recognized. There is a surgery that can reverse that, but it's not foolproof. But don't confuse the use of 100% high flow oxygen on a neonate long term with using it short term. It's okay short term, but we're talking long term use of 100% oxygen can cause blindness in neonates. So don't confuse that too much. Acquired causes of visual impairment is going to include trauma, which of course is the leading cause of visual impairments. Stroke can lead to vision loss depending on the area of the brain that's affected. Central venous and central arterial occlusions can cause sudden vision loss. Age-related macular degeneration gradually impairs central vision. Glaucoma causes a progressive damage to the optic nerve. Cataracts cloud the eye lenses and lead to blurry vision. However, cataracts are very treatable. Diabetic retinopathy is a complication of diabetes that affects the retina. Uncontrolled hypertension can cause damage to the blood vessels of the eye. We can have a degeneration of the eye, the optic nerve, the nerve pathways, any one of these areas that can result in vision loss. If there's a vitamin A deficiency, it may lead to night blindness and overall vision decline. There may be some optic nerve hypoplasia, which is a congenital condition where the optic nerve does not fully develop. There could be even optic nerve atrophy that results from CVA or something along those lines. Brain tumors may cause pressure on the optic nerve, leading to atrophy. Exposure to certain toxins and chemicals can damage the optic nerve. Trauma may damage the optic nerve and cause atrophy due to either direct or indirect injuries. Optic nerve atrophy can also occur from a variety of other medical conditions. So visual impairment can present in several distinct patterns depending on what the cause is. Acute angle closure glaucoma is a true ocular emergency. However, we're not going to be able to diagnose that in the field, but patients with acute angle closure glaucoma experience sudden, severe unilateral eye or paraorbital pain with vision changes. So while we won't be able to absolutely diagnose it in the field, we should have a pretty good idea that there's something serious going on within the eye. And anytime there's sudden onset of unexplained severe eye pain with visual changes, we should treat it as a true emergency because it could be glaucoma related. Prompt recognition of this and emergency transport are absolutely essential if there's any hope of being able to preserve that patient's vision. So always warn the patient before touching them, a particular body region or part of the body when performing procedures like starting an IV. These patients have this visual impairment, so they can't see what you're doing. So you need to be very clear in explaining and talking about any movements or things that you plan to do so that the patient is fully aware of what is going on. Remember, you have to be their eyes for the world during the time that you have them, and it's really important that you make sure that you're communicating clearly with them what your intentions or what you're planning on doing before you do those things. And then we have people that have speech impairments. Impaired speech may be associated with some sort of a neurological injury that may be related to stroke or any number of things. Could be a toxic exposure that may cause some speech difficulties. There could be just some anatomical abnormalities of the face and neck that can affect speech. And there's numerous other medical conditions that can also lead to some form of a speech impairment. Speech disorders are generally divided into two categories based on the area that's affected. Articulation disorders involve forming specific words or sounds correctly. These are, typical examples of articulation disorders usually include things like lisps or trouble with particular sounds. These are typically associated with nerve issues, innervement, being able to control or articulate or move those speech muscles in a way that produces speech in a normal way or in a standard way. Voice production disorders are going to alter the pitch, volume, and tone of the voice. And of course, voice changes may cause speech to sound muffled, raspy, or unusually high or low. Fluency disorders may affect the pattern of speech, and fluency issues can include unusual pauses, prolonged words, repeated words, or avoided phrases. Language disorders impair how ideas, thoughts, and feelings are expressed or even understood. So a patient with a language disorder may understand what they want to say, but they may struggle greatly finding the right words or phrases for how to say it. Language-based learning disabilities cause difficulty with reading, spelling, writing, and this leads to delays compared to their peers. Phonologic process disorders affect the ability to produce sounds that combine into spoken words. Semantic pragmatic disorder of speech is often seen in patients with autism. This disorder is characterized by delayed language development milestones. Patients may repeat irrelevant phrases that are out of context. They may confuse word pairs such as I and you. They may get them backwards. Trouble following a conversation is very common with these people. Both the reception and expression of communication are affected. Dysrhythmia results from failed neurotransmission between the nervous system and the muscles of the face and throat, impairing speech. So it's not that the brain is not functioning right, it's the nerve impulses between the brain and those speech muscles. This is characterized by consistent repetition of the same speech impairment. Apraxia is a neurological condition where the brain impairment causes inconsistent activation of muscles used to form sounds or words. Patients with apraxia understand what they want to say, but the muscle activation is not consistent, it's irregular, and it makes the speech correction process difficult. And then we have things like paralysis, paraplegia, quadriplegia. Paralysis, of course, is quite simply the inability to move. Muscles in the affected areas may become flaccid or remain in spasm state, known as spastic paralysis. Long-term paralysis can result from many medical conditions. Head trauma, of course, is one of the most common causes of paralysis. And of course, cerebral vascular accidents or strokes can lead to paralysis as well. Spinal cord injuries are often a cause of paralysis. And there may be some malignancies that affect the nervous system that can cause paralysis as well. There's some other neuromuscular diseases that can result in long-term paralysis. We'll talk about a few of those a little bit later. Paraplegia is paralysis that affects the lower extremities but not the upper extremities, whereas quadriplegia affects both the upper and lower extremities. Paralysis is often accompanied by sensory deficits and the loss of bowel or bladder control. Patients with paralysis often face some serious complications. Respiratory muscle paralysis can impair breathing. Pressure ulcers are very common with paralyzed patients because of the extended period of time that they spend either sitting or lying. Frequent position changes are necessary using mechanical devices or caregivers to prevent pressure ulcers. Prolonged external pressure reduces tissue perfusion over those bony areas like the coccyx, leading to pressure sores. And then the infection from these pressure sores is a significant cause of mortality among this group of patients. Autonomic dysflexia is a risk for patients with spinal cord injury-related paralysis. This condition is when a body stressor triggers catecholamine release from the autonomic nervous system, and this causes vasodilation above the spinal cord injury and massive arterial vasoconstriction below. The result is a dangerously high blood pressure. External devices like halo rings and vests are often used to stabilize the spine. These devices require extra care and coordination when moving the patients. These devices, or halo rings and vests, are heavy and add a substantial weight to the patient's, substantial weight overall to the patient. It is necessary to support these devices without applying force directly on them during movement. Removal of these devices should only occur during cardiac arrest to allow for adequate chest compressions. Patients with paralysis are essentially vulnerable to environmental extremes. They most often cannot regulate skin perfusion effectively and manage heat and cool. So the autonomic nervous system fluctuations actually increase the risk for both hypothermia and hyperthermia. Loss of sensation is not always present in these patients. Some patients may have normal sensation or even have heightened sensitivity. Pressure that is normally felt may go unnoticed, and some male patients with severe spinal cord injuries may actually experience a priapism. Many patients require urinary catheterization to manage their bladder functions, and failure to empty the bladder regularly can lead to bladder infections. Urinary reflux is another possible complication of poor bladder management. Autonomic dysflexia may also result from bladder issues. Total lifting assistance is usually needed for any patient movement, and additional assistance may be required for devices such as tracheostomy tubes, indwelling urinary catheters, colostomies, and ventilators. So trauma in the cognitively impaired patients can be difficult sometimes to deal with. Most cognitive impairments cause challenges during traumatic events. Isolated sensory and communication impairments can cause a large increase in anxiety, and these impairments may also cause confusion. Delays in care can result from communication barriers because the patient doesn't understand what needs to be done or is fearful about what's going to happen. Patient care or transport may be disrupted due to these types of impairments. Patients with severe cognitive impairments may show abnormal behavior responses in these situations. So EMS personnel are often need to modify their communication strategies in order to be able to effectively treat and transport these patients. Assessment approaches may need to be adjusted as well, and interventions might require adaptation to the patient's needs. Patient transport should be carefully planned and accommodate the severity of the impairments. Effective communication with a traumatized, cognitively impaired patient may be nearly impossible. The patient may be unable to provide a thorough or meaningful medical history, and if a caregiver is not available, we're going to have to rely on the patient's physical and behavioral cues to give us an indication of their medical history. Environmental clues can also help identify the nature of the disability, and examples include group homes, specialized schools, or lettering on vehicles may be an indication that you're dealing with a patient that has a cognitive impairment and maybe perhaps some other special needs. Many people with profound cognitive impairment may have altered or decreased pain sensations as well, so you may find injuries or wounds on them that they themselves may not have known about yet. They may also have concomitant neurological disorders as well, so along with their cognitive impairments, there may be some other neurological disorders, that they're carrying with them as well. Physical signs and symptoms can present atypically in these patients, so you have to really look deeply for some clues about what is going on and how they're maintaining. Medical treatment is going to be medical treatment consistency may be uncertain in these patients, so it may be hard to be consistent with treatment with them. Adults with profound impairment often lack the capacity to consent or refuse treatment. It may be necessary to locate a valid surrogate to help make decisions for the patient. In emergencies, treatment can be initiated under the doctrine of implied consent, even for a fully conscious patient that may be refusing, but their cognitive impairment may kind of preclude them from being able to fully refuse consent. Patient assessment techniques will likely need to be modified for these patients. Some patients may have education levels at or below the 6th grade, so you need to keep that in mind. And patients may struggle to understand or communicate the timing and relationship of events. They may not understand that the event and the trauma associated with that event are tied together. Using open-ended questions can typically help assess cognitive abilities and their ability to make decisions. Ask the patient to paraphrase information back, especially when obtaining consent or refusal. Caregivers are very valuable resources after a traumatic event with these patients. They can explain how the patient normally communicates, and caregivers can share the patient's level of awareness and understanding. They can provide information on physical abilities and intellectual capacities. Additional details like sleep patterns and eating habits may also be helpful in certain situations. Consider allowing the caregiver to stay with the patient during the physical exam, and you may defer vital sign measurements in patients who show adequate oxygenation, ventilation, and perfusion until they calm down and become more cooperative and that those procedures seem less invasive to them. Interventions may take more time, explanation, and assistance to accomplish, And management of traumatic injuries is usually the same as with other patients. It just may take more time. Be prepared for other neurological disorders such as seizures, delirium, weaknesses, and muscle spasms to be present in these patients. And there may be even some psychiatric, gastrointestinal abnormalities. Chronic or frequent infections are also pretty common. Always assess and treat any pre-existing injuries that you find. Check carefully for signs of abuse and neglect because, as mentioned previously, these are the things that can kind of fly under the radar with this group of patients. So we always want to be extra vigilant and keep an eye out for that, not assuming that every one of these patients with cognitive impairments are going to be abused. But remember, you're going to be the only opportunity for them to be able to seek help for those conditions. All right. So let's take a look at some other kind of notable chronic medical conditions, and this is probably where we're going to spend the remainder, or at least the bulk of the remainder of this chapter, on talking about some of these chronic medical conditions. Some of them we've talked about before, others are going to be relatively new. Cancer is one of those we've talked about fairly extensively, but this is basically to refresh on this, it's the result from an excessive growth and division of abnormal cells in the body. It may remain stable with minimal symptoms, or it may progress rapidly, leading to death in a short amount of time. Cancer commonly affects organs and body systems such as the brain, breast, lungs, skin, blood, stomach, liver, immune system, and of course the colon. Abnormal cells cause illness by multiplying within an organ or by spreading, called metastasizing, into other areas. Signs, symptoms, and treatment depend on the cancer's location or primary site of origin. Treatment options are going to vary and may include radiation, chemotherapy, medications, immunotherapy, stem cell transplantation, or surgical removal. Cancer treatment can increase susceptibility to other unrelated medical conditions. Chemotherapy medications may cause nausea and vomiting. Loss of appetite is a common side effect of chemotherapy, and patients may experience general discomfort during treatment. Chemotherapy often compromises the immune system and increases the risk of infection. Patients often receive chemotherapy, analgesics, and blood products through implanted ports or long-term vascular access devices. These devices reduce patient discomfort, they prevent irritation of smaller blood vessels, and they provide reliable access for frequently administered medications. You may need to correct some dehydration issues with these patients or administer some pain or antiemetic medications. Always ask about and inspect for transdermal patches before giving medications. Ask the patient about their wishes regarding resuscitation, and if applicable, obtain copies of advance directives or DNR orders and associated paperwork. Cerebral palsy is a non-progressive neurogenic disorder caused by injury to the brain tissue. This injury can occur during fetal development, and it may also happen during the labor and delivery phase. Injury during the first 2 years of life can lead to cerebral palsy. Cerebral palsy can be caused by genetic defects as well. Maternal infections during pregnancy may lead to cerebral palsy. Fetal stroke is a possible cause. Excessive fetal bilirubin or hemolysis can cause brain injury. Hypoxia before or during birth is a common cause. And infant infections such as postpartum encephalitis or meningitis may result in cerebral palsy. Head trauma during early childhood can also cause the development of cerebral palsy. The usual cause of cerebral palsy cerebral palsy usually results in altered skeletal muscle function and coordination. The muscles may be poorly controlled and appear unusually contracted, flaccid, or paralyzed. The severity of the symptoms is going to range from almost unnoticeable to profoundly devastating. Severe cases may include paralysis of both arms and legs and severe intellectual disabilities. Those more severely affected often have chronic symptoms such as seizure disorders. Hearing loss may also be present, and various other neurological disorders can accompany cerebral palsy. Cerebral palsy may affect only certain body regions, or it may affect the entire body. Hemiplegia involves paralysis on one side of the body, and paraplegia affects either the arms or the legs. Spastic tetraplegia impacts all four limbs. Movement disorders associated with palsy include tremors. Patients may have an unsteady gait. Involuntary writhing movements is another common symptoms. Severe cases may involve seizures as well. Loss of bladder control can occur. Some patients may have difficulty swallowing. Joint contractures are possible, and respiratory function may be impaired as well. Careful movement and positioning of these patients is essential during treatment and transport. Realize that this is much less about the actual extremity or limbs that are affected, and it's much more about the nerves or the control center in the brain that innervates those particular areas of the body. Those nerves are just either damaged, or they're not present, or they're present only in limited quantities, so the movements can be jerky and seem uncoordinated or difficult because of the damage to the nerves that would help create some of the fine motor movement. Congenital heart disorders in adults, we talk about these in pediatrics in the pediatric section, but sometimes those pediatric patients actually grow to adulthood. And then we wind up with congenital heart abnormalities or heart diseases that involve the heart or great blood vessels. The severity can range from insignificant to immediately life-threatening. Typically, the patient, family members, or caregivers are going to be the best source of information. They're almost always very familiar with whatever condition that they have. Significant physiologic stressors like pneumonia, pregnancy, and sepsis can complicate an otherwise stable congenital heart defect condition. So we're going to need to reach out to medical control for assistance before administering a whole lot of fluids, vasoactive medications, or similar interventions, just to make sure that we're on the right path and we're not going to make things worse with these patients with these congenital diseases. Consider that there may be an undiagnosed congenital heart defect if a patient has a heart murmur along with signs and symptoms of heart failure. So we want to make a consideration there that there may be something to that. Cystic fibrosis is a genetic disorder that causes increased mucus production in the lungs and the digestive tract. It results from a defective recessive gene inherited from each parent. This defect makes it difficult for chloride to move through the cells, and the condition causes unusual high sodium loss. Mild cases may go undetected in childhood. Now, cystic fibrosis, not to be confused with just the term general fibrosis. There are patients out there that have had scars from exposure to smoke and those kinds of things, and they have lung fibrosis. It's not the same as cystic fibrosis, though sometimes the signs and symptoms are the same, minus the sodium loss and the difficulty with chloride. Those are typically not things that you find in just a general lung fibrosis case or digestive fibrosis case. Remember, cystic fibrosis is kind of its own animal. The sweat glands of a cystic fibrosis patient may also be affected, as well as the reproductive glands. Other body systems can also suffer the adverse effects as well. Increased mucus production can impair respiration, and that's oftentimes a big sign that we see with cystic fibrosis. And of course, the fibrosis in the digestive tract can impact and disrupt food digestion. In severe cases, increased mucus can cause life-threatening emergencies and lung infections. Cystic fibrosis is suspected in newborns who present with meconium ileus. Odd-smelling or pale, greasy-looking, foul-smelling stool is another sign of cystic fibrosis in infants. Gastric and gastrointestinal symptoms are going to include things like nausea and anorexia. Patients may experience constipation as well as pancreatitis. A distended abdomen is common. Bowel obstruction and ileus can occur. The release of pancreatic enzymes needed to digest and absorb fats are often impaired. Patients are at high risk of developing venous thrombosis, and pulmonary symptoms are going to include pneumonia and pneumothorax. Persistent cough and respiratory distress is pretty common, and respiratory failure may develop in some of the more severe cases. When you think of cystic fibrosis, think of it as scars that develop in those particular organs that are affected. For instance, in the digestive tract, these scars along the digestive tract develop, and if they're close to the pancreas or close to the exocrine parts, or the exocrine parts of the pancreas, then that pancreas's ability to release those digestive enzymes into the digestive tract is hampered because of that, and it is a fibrotic kind of thickening that happens. So it's a fibrous scar, almost like, that happens along the digestive tract and in the lungs, but that fibrous scar also produces a lot of mucus and those kinds of things. So it's kind of a twofold thing, and that's why it's similar but not the same when we talk about someone with pulmonary fibrosis versus cystic fibrosis. It's similar, and we'll see some similar signs and symptoms in the respiratory side of things with the pulmonary fibrosis, but it's not necessarily the same disease process, and maybe not even near the same cause. Other symptoms of cystic fibrosis are going to include malnutrition with a poor growth rate. Patients may experience failure to thrive. Infertility could be an issue as too. Chronic sinus congestion is common. Bone mineral losses. Medical devices may be used for long-term vascular access. Devices also may be used to promote lung function and mucus removal. And intermittent or continuous home oxygen therapy is not unusual and may be required in many cases. Patients often have long, complex medical histories and many other clinical abnormalities. Expect to administer oxygen as needed, so you may need to increase the amount of oxygen that you're delivering. Frequent deep suctioning may be necessary, and assisting ventilations may be required. Cystic fibrosis is usually diagnosed in infants and children, and then they progress to adulthood. Diagnosis requires specialized testing that is not available in the pre-hospital setting. So always alert the receiving facility of if you think cystic fibrosis is suspected, but more than likely they're going to already be diagnosed with that condition. Multiple sclerosis is a severe, incurable degenerative disorder of the central nervous system, which includes the brain and spinal cord. What happens is immune cells begin to attack the myelin sheath that covers certain nerve fibers. This damage then prevents the proper nerve transmission to other body systems, and this image on your screen kind of shows the destruction of those myelin sheaths. And once enough of that destruction of that happens, the nerve impulse no longer can be transmitted. As it progresses, though, as the sheath begins to become damaged, the nerve transmission along that nerve, or the electrical transmission along that nerve, becomes disruptive and slowed down. So then you start to see some of those jerky movements that's pretty common with multiple sclerosis. The cause of multiple sclerosis is really unclear, but some factors are linked to developmental issues, including a genetic predisposition, some environmental factors, nutrition, and exposure to particular viruses. It affects women in their 20s to 40s 2 to 3 more times more often than men, And approximately about 400,000 Americans have multiple sclerosis. Common symptoms involve problems with muscle coordination and muscle tone, and patients may experience altered sensation and gait disturbances. The disease often follows a pattern of periods of improvement, followed by relapse and then progression of the disease. Signs and symptoms affecting neurological function include musculoskeletal problems. Patients may experience clumsiness and ataxia. Of course, constipation and bladder incontinence can occur as well. Fatigue is very common. Extremities may feel heavy or weak. Altered sensations like dizziness or vertigo can happen. Numbness or tingling in the body is frequent. Cognitive impairment may develop. Speech or swallowing can be disrupted. And they may even have some visual impairment and skin breakdown issues as well. Severe cases may actually leave patients bedridden and incontinent. Symptoms often present in combinations and can last days to months with symptom-free periods in between. Management includes medications, physical therapy, and of course counseling. There's no specific EMS treatment for multiple sclerosis in the field, but you should allow extra time for your assessment and realize that patients may lack sensation, which may make physical exams much more harder to interpret. Supportive care includes IV hydration, administering analgesics and muscle relaxing medications as needed. Position the patient carefully to avoid injury and provide ventilatory assistance as needed. Muscular dystrophy is a group of incurable genetic diseases that causes slow, progressive degeneration of muscle fibers. Specific types of muscular dystrophy can be diagnosed by certain genetic markers. Diagnosing also depends on the age at onset, rate of the disease progression, and the patient's gender. Children with muscular dystrophy may show facial muscle changes. They may have an altered gait. They may have delayed motor development, and they may miss some of those more common psychomotor development milestones. Changes in posture can also be observed. Severe cases may involve cardiomyopathy, cognitive impairment, respiratory compromise. Muscular dystrophy signs may appear at birth or start later in adulthood. Profound symptoms or death in children and teenagers usually result from cardiac or respiratory failures. Duchenne muscular dystrophy is the most common type of muscular dystrophy. It's caused by a sex-linked recessive gene. This mainly affects boys and is characterized by enlarged heart muscle and also dilated cardiomyopathy, also called dilated cardiomyopathy. Heart dysrhythmias are common. Patients often develop scoliosis of the spine. Gait disturbances are typical, and most patients end up being wheelchair bound by the age of 15. Treatment for these patients is mainly going to involve careful positioning of the patient. Supportive treatment is essential, and assisting ventilation is needed in some of the more severe cases. Myasthenia gravis, we've talked about this one a little bit before, and this is that rare autoimmune disorder that affects the neuromuscular transmission, causing weakening muscles, and patients oftentimes tire very easily. It affects all ethnic groups and sexes, but it's most common in women under 40 and men over 60. Ocular myasthenia gravis affects the eyelids and extraocular muscles. Generalized myasthenia gravis affects respiratory muscles and various skeletal muscles, including the jaw, neck, and upper extremities. Patients may have difficulty speaking, chewing, and swallowing. Myasthenia crisis occurs when respiratory failure happens due to respiratory muscle fatigue. This crisis can be triggered by infection, stress, medication, side effects, or even menstruation. Signs and symptoms fluctuate over time and include drooping eyelids, double vision, difficulty chewing and speaking or swallowing, and muscle weaknesses of the extremities. EMS may be called for complications of the disease for unrelated issues. Treatment is generally supportive and based on the patient's presentation. A myasthenic crisis may require airway protection and assisting ventilations. All right, spina bifida is a birth defect caused by improper development of the fetal neural tube. It's a defect of the vertebral column that creates an opening that exposes the spinal cord and the meninges. This exposure leaves the spinal cord and meninges vulnerable to the outside environment. It may cause problems with bowel and urinary elimination, and patients may also develop scoliosis or other orthopedic disorders. Surgical treatment usually happens within 2 days of birth, and in some cases, surgery is performed while the patient is still in the mother's uterus, or in utero. Usually diagnosed with routine prenatal ultrasounds, and then of course after delivery, we want to cover this. If we deliver a baby with spina bifida, we want to make sure we cover the smaller spinal cord openings with a moist sterile dressing and cover the larger openings with a sterile occlusive dressing to help prevent neonatal hypothermia and drying those out. Place the newborn in a prone or lateral position to protect the exposed spinal area and transport immediately to a specialized facility that can manage that newborn. Infants, children, and adults with prior surgical correction for spina bifida are likely to require careful positioning due to the vertebral column and orthopedic abnormalities. They usually present with issues related or unrelated to their spina bifida. Some patients with spina bifida experience bladder dysfunction, which often means they need frequent urinary catheterization. Curvature of the spine is common in this group. They may have other neurological conditions such as seizure disorders, hydrocephalus, cerebral palsy, and intellectual disabilities. Leg paralysis, either partial or complete, is frequently seen, and various bones and joints may have abnormalities as well. Patients with spina bifida almost always have an allergy to latex, so it's important to make sure that you're not using latex gloves when you're caring for these patients or using any kind of equipment that may contain latex. Polymyelitis is a viral infection that causes significant illness and death worldwide. Poliomyelitis, if I can even say the word. Aggressive vaccination campaigns have eradicated polio in many countries, including the United States. Despite the fact that there are no new cases, many people still live with some profound effects of polio. Humans are the only known host of polio, so isn't that wonderful to know? We can't even blame it on the bats or anything else. Polio initially presents with common viral-like illness, including headaches, sore throat, fevers, malaise, and vomiting, all those normal things you would expect to see with a virus. However, as the disease progresses, symptoms such as back pain, diarrhea, leg pain, continued fever, and muscle discomfort or stiffness may appear, somewhat similar to some of the COVID signs and symptoms we were seeing in the early days of COVID. Two main forms of polio. There's the non-paralytic form, which results in complete recovery, and then the paralytic form, which causes muscle weakness that can progress into paralysis, usually affecting the legs and lower trunk. Whereas we had a former president of the United States that was a polio survivor, a paralytic form of polio survivor. Other symptoms of paralytic form include muscle spasms, respiratory distress, drooling, and difficulty swallowing. Complications of poliomyelitis can include hypertension, respiratory failure, myocarditis. Shock is another possible complication. Loss of intestinal function can develop over time, and in severe cases of polio, it can lead to death. Survivors of polio are at risk of post-polio syndrome. This syndrome is marked by progressive or sudden worsening of muscle weakness. Muscle atrophy is commonly seen in these cases. There is a renewed risk of respiratory insufficiency and respiratory failure among this group. Of course, difficulty swallowing can develop as well, and speech can become impaired. Students often experience significant pain or fatigue when the post-polio syndrome begins to show up. Long-term outlook is favorable for subclinical polio, which causes brief, mild symptoms lasting less than 72 hours. Most cases of polio in children are asymptomatic, about 70% of them. So treatment's going to mainly focus on supportive care. Assisted ventilation and oxygen should be provided for patients with acute or impending respiratory failure. Movement and use of EMS standard equipment can cause significant discomfort to these patients, so you may need to modify your approach or the equipment that you use on them. Assist patients carefully with transfers of movement, and then of course positioning and padding is going to be really beneficial to them, and it's going to really help with their care. Patients with lower body paralysis may need urinary catheterization as well. The last topic of chapter 46 is going to be traumatic brain injury. This is a potentially devastating condition that can cause many serious short and long-term complications. It now includes a wide range of disorders affecting cognitive, emotional, behavioral, sensory, and communication functions. Patients may show seizures, impaired movement, gastrointestinal dysfunction, urinary retention, or paralysis. Be prepared to encounter patients with a wide range of impairments or complications when it comes to traumatic brain injury. It's not going to be the same for any two patients. It's going to be very unique to that particular patient. So bear that in mind. Realize that many of these patients are actually relatively cognitively intact. However, they lose their ability to be able to communicate well or understand things well because of the location of their brain injury. And it may cause a lot of physical impairments too. So the location and severity of that injury, of their brain injury, can make assessing and making transport decisions quite challenging. So realize that you're going to have to take a little extra time. Having some assistance from the caregiver is absolutely essential for our patient interactions and distinguishing new symptoms from pre-existing things that are already going on. So don't be afraid to ask lots of questions for clarifying. Patients may not be able to, or they may be unwilling to provide a meaningful history or details about their illness or condition. Realize that these patients have spent a lot of time in and out of medical facilities and those kinds of things, and they sometimes get quite tired of repeating all of the same things over and over again. Communication and other routine tasks may require extra time and attention as well. So in extreme cases, patient restraint may be necessary if safety concerns begin to arise for the patient or the EMS providers. It just all depends on with brain injuries, it's all about location, and severity of where those symptoms are going to show up. So that is some of the special challenges that we may encounter in the EMS setting. Realize that what we've talked about is not all inclusive, and really just literally skimmed the surface of these so that it's much more of an awareness than it is you're enhancing your ability to provide really direct, meaningful care to these patients and their conditions. So if you wind up leaving the ambulance and going to work somewhere where you're going to be caring for these individuals, realize you're going to have to kind of bolster your education so that you have a better understanding about some of these special challenges if you find yourself working in a facility that cares for people with challenges like the ones that we've mentioned. All right, so that's chapter 46. See you guys back at chapter 47.